Welcome to this video on Kawasaki disease, a pediatric vasculitis. We will cover the disease based on the content of Nelson's textbook of pediatrics. Our learning objectives for this video are to define Kawasaki disease, recognize its clinical presentations, apply diagnostic algorithms, and understand its pathogenesis and phases. We will also cover cardiac complications, treatment, and long-term follow-up. We begin with Module 1, an introduction and history of Kawasaki disease, focusing on its discovery, definition, and epidemiology. Kawasaki disease was first observed in 1961 by Dr. Tomosaku Kawasaki. Coronary artery involvement was recognized in the 1970s. Key updates on diagnosis and management were published by the AHA in 2017 and 2024. Kawasaki disease is an acute, self-limiting systemic vasculitis of medium-sized arteries, preferentially affecting the coronary arteries. It is the leading cause of acquired heart disease in children in developed countries. Key epidemiological points include an incidence of 25 per 100,000 children under 5 in the USA, with 80% of cases occurring between 6 months and 5 years. Without treatment, 25% of affected children develop coronary abnormalities. The etiology remains unknown, but evidence points to an infectious trigger in genetically susceptible individuals. This is supported by its self-limited nature, wave-like spread, and seasonal predilection. The pathogenesis involves immune-mediated vasculitis. An environmental trigger leads to immune system activation, causing inflammation. This damages the arterial wall, potentially leading to aneurysm formation, especially in the coronary arteries. Kawasaki disease progresses through 3 phases. The acute phase features spiking fever and classic signs. The subacute phase is marked by fever resolution, desquamation, and the highest risk of sudden death. The convalescent phase involves the normalization of lab values. Module 2 covers the clinical features and diagnosis, including the classic criteria, incomplete Kawasaki disease, and the diagnostic algorithm. Classic Kawasaki disease is diagnosed with a fever of at least 5 days, plus 4 out of 5 principal features. These features are bilateral conjunctival injection, oral mucosal changes, extremity changes, polymorphous rash, and cervical lymphadenopathy. Fever is the cardinal feature, typically high, spiking, and unresponsive to antibiotics. It must be present for at least 5 days for a classic diagnosis and resolves within 36 hours of IVIG treatment in 85% of patients. Bilateral conjunctival injection is non-purulent and exhibits limbal sparing. Oral changes include cracked red lips, strawberry tongue, and diffuse oropharyngeal erythema. The absence of exudates in the pharynx helps differentiate it from strep throat. Acute extremity changes include erythema and swelling of the hands and feet. In the subacute phase, periungual desquamation or peeling begins. The rash is polymorphous and non-vesicular, with early perineal desquamation being a helpful indicator. Cervical lymphadenopathy is the least common feature, usually presenting as a single, firm, non-fluctuant node greater than 1.5 centimeters. Failure to respond to antibiotics should prompt an evaluation for Kawasaki disease. Other clinical features of KD affect multiple systems. Cardiovascular effects include myocarditis and valvular regurgitation. Gastrointestinal symptoms include diarrhea, vomiting, and hepatitis. Musculoskeletal features involve arthritis, particularly in large joints. Incomplete Kawasaki disease occurs when patients have fewer classic features, making diagnosis challenging. This form is often seen in infants under 12 months, who are at the highest risk for coronary aneurysms. The criteria for suspicion rely on fever, fewer principal features, and specific lab criteria. The American Heart Association diagnostic algorithm helps evaluate patients. A classic diagnosis requires fever and 4 or more principal features. If fewer features are present, an evaluation of inflammatory markers and supplemental lab criteria guides the next steps, including obtaining an echocardiogram and initiating treatment. Laboratory findings support the diagnosis. CRP and ESR are almost universally elevated in the acute phase. Other findings include leukocytosis, anemia, hypoalbuminemia, and sterile pyuria. ESR normalizes later in the convalescent phase. Kawasaki disease can mimic many childhood febrile illnesses. It is crucial to distinguish it from conditions like scarlet fever, measles, viral infections, Stevens-Johnson syndrome, and MIS-C, especially since some of these can coexist. We now move to Module 3, focusing on cardiac complications, including coronary artery aneurysms and myocardial involvement, which are the most critical aspects of this disease. Cardiac involvement occurs in both acute and subacute phases. Acute issues include myocarditis, pericarditis, and heart failure. Subacute and chronic involvement includes coronary artery dilation, aneurysms, and the risk of thrombosis or myocardial infarction. 20 to 25% of untreated patients develop coronary artery abnormalities. Aneurysms are classified using Z-scores, which normalize coronary dimensions. Giant aneurysms carry the highest risk of severe complications, although about 75% of aneurysms regress. Echocardiography is vital, conducted at diagnosis and during follow-up. It assesses coronary artery dimensions using Z-scores, ventricular function, and other cardiac abnormalities. The maximal Z-score determines the long-term risk category. Module 4 covers treatment and management, including IVIG, aspirin, managing refractory cases, and adjunctive therapies. Intravenous immunoglobulin, or IVIG, is the first-line therapy. Administered as a single dose, ideally within 10 days of onset, it reduces the risk of coronary artery abnormalities significantly. Patients require monitoring for side effects and delayed live vaccine administration. Aspirin therapy is given in 2 phases. High-dose aspirin is used in the acute phase for its anti-inflammatory effects. Low-dose aspirin is used in the convalescent phase for antiplatelet activity, continued until coronary changes resolve, or indefinitely if abnormalities persist. Refractory Kawasaki disease is diagnosed if fever persists or recurs 36 hours after initial IVIG. These cases require additional, specialized treatment strategies. Key updates from the 2024 AHA statement emphasize identifying high-risk patients, such as infants, or those with baseline coronary dilation. These patients require intensified primary therapy and close monitoring for evolving aneurysms. DOACs are now alternatives for anticoagulation in giant aneurysms. Finally, Module 5 addresses risk stratification and follow-up, covering long-term management and prognosis for children affected by Kawasaki disease. Risk stratification in Kawasaki disease is based on the maximal coronary artery Z-score observed during the illness, guiding long-term cardiology surveillance and management. Long-term management for all patients includes cardiovascular risk factor counseling. Patients with coronary artery aneurysms need lifelong cardiology follow-up and serial echocardiography. Activity restrictions are based on the severity of the coronary involvement. Predictive scoring systems, like the Japanese Kobayashi score, help identify IVIG resistance. The 2024 AHA criteria define high risk as age 6 months or less, or a baseline coronary Z-score of 2.5 or greater in the LAD or RCA, warranting intensified initial treatment. Prognosis is generally favorable with treatment. Coronary abnormalities occur in about 4% of treated patients. Most aneurysms regress, but giant aneurysms rarely do. Mortality is low, but major adverse cardiovascular events occur in about 5% of patients with CAA. Key takeaways include recognizing KD as the leading cause of acquired heart disease in children. Prompt IVIG within 10 days is vital, and patients with coronary aneurysms require lifelong cardiology follow-up. The 2024 AHA update emphasizes high-risk identification. These are the references used in the preparation of this video, including key guidelines from the AHA and content from Nelson's textbook of Pediatrics. Thank you for watching this video on Kawasaki disease. We hope this has been informative for your practice.